In India's rural and semi-urban communities, finding a licensed primary care doctor is a logistical challenge. There is a profound structural void in the healthcare system, leaving millions without direct access to modern medical expertise. Faced with this infrastructure deficit, people with minor fevers, persistent aches, or coughs naturally look for the closest option to find immediate release. This search often leads them to local medical halls and neighborhood clinics. The transaction is simple. The patient presents their symptoms, and they are handed a handful of unlabeled pills to make the pain vanish overnight. But the individual standing behind the counter, handing over these treatments, is frequently not an allopathic doctor. They are often entirely unqualified or trained in traditional disciplines like Ayurveda or homeopathy, operating outside their legal domain. This practice of unauthorized prescribing drives an increasing number of drug-induced metabolic, renal, and microbiological crises across the population. Many of the pills handed out in these quick-fix transactions belong to a heavily restricted category known as Schedule H drugs. By law, these highly potent therapeutics can only be dispensed with a verified prescription from a licensed medical professional. What begins as an innocent attempt to treat a common cold pulls vulnerable patients directly into a systemic, unregulated medical trap. To understand the true cost of this structural failure, we must look past the local clinic and examine exactly what these unauthorized pills are doing inside the human body. One of the most common treatments handed out is corticosteroids. Drugs like dexamethasone are given out indiscriminately to provide rapid, almost magical relief from minor viral aches and pains. This visualization shows the drugs shutting down immediate inflammatory responses, masking symptoms while quietly triggering severe metabolic damage, leading to type 2 diabetes and hypertension. Concurrently, routine dispensing of broad-spectrum antibiotics for viral infections forces bacteria to mutate, accelerating antibiotic resistance. As these pathogens adapt, standard-line life-saving drugs are rendered completely ineffective, stripping communities of their primary defense against severe infections. The traditional practitioners dispensing these drugs are imitating modern clinical pathways. However, they lack the rigorous pharmacology training required to predict or manage these cascading biological outcomes. These unauthorized treatments are not curing the patient. They are manufacturing entirely new, lifelong chronic diseases. The damage deepens with the widespread distribution of heavy drug cocktails. These mixtures, packed with powerful NSAIDs, are heavily abused as a quick management tool for chronic pain. Consuming these cocktails pushes the body through a dangerous progression. It begins with acute kidney injury, which, under continuous exposure, degrades into irreversible drug-induced renal failure. This raises a critical question. How are highly restricted Schedule H and H1 therapeutics consistently making their way into the hands of unqualified local practitioners? The path these drugs take reveals a massive breakdown within the pharmaceutical supply chain. Wholesale distributors and retail pharmacies frequently bypass established safety laws to maintain volume and profit. Across the country, potent therapeutics are dispensed over the counter on a daily basis, with no one requiring or checking for a verifiable prescription from a licensed medical doctor. This table identifies the recognized clinical consequences of this unauthorized prescribing. Health authorities have explicitly mapped the specific mechanisms of misuse for these drugs directly to the long-term pathologies they create. The physical destruction of the patient's body is fueled by a profit-driven supply chain operating within a fragmented regulatory landscape. The responsibility for this crisis ultimately falls on the fragmented oversight of national and state regulatory bodies. State medical councils often fail to aggressively enforce existing anti-quackery laws. This inaction blurs the strict legal boundaries that are supposed to separate modern allopathic medicine from traditional disciplines. Furthermore, conflicting state policies create loopholes for mixopathy, a leniency that allows the dangerous blending and cross-practice of entirely distinct medical systems. The judicial system has already provided a remedy. Precedents like the landmark Supreme Court ruling in Poonam Verma v. Ashwin Patel draw a hard line. That ruling firmly establishes that practicing any system of medicine without the appropriate registration and specific training constitutes professional negligence. Halting this trajectory requires structural enforcement. This means implementing digitized, centralized e-prescription portals that securely track every Schedule H drug from distributor to patient. But infrastructure takes time. Right now, the most immediate line of defense is public health literacy. Communities must be educated on the severe dangers of these instant cure cocktails, and patients must learn to actively request and verify the credentials of their medical professionals. Until statutory loopholes are permanently closed and the supply chain is secured, a patient's only true shield against this man-made epidemic is rejecting the promise of an instant cure and verifying exactly who is writing the prescription.